Right, so I came to my first multidisciplinary postgraduate meeting, I think either in this room, but definitely in this building, way back, probably about 28 years ago, I think, with a colleague, Otto Chan. Some of his work's in here. And this guy from Philadelphia got up on the stage and was introduced as the expert in, I think it was musculoskeletal conditions of the spine and radiology. And he laughed. He was a little guy in a blue suit. And he laughed and he said, an expert is defined as somebody from another city with lots of slides. So I'm from Tower Hamlets, about 20 minutes on the Hammersmith and City line, and I've got about 25 slides, so I'm no expert, but it's a lovely little circular journey. Thank you, Charlie, for the introduction, and to Courtney and to Rebecca also for the invite and all the organisation. And thanks for asking me to talk about Achilles tendinopathy rehab, which we've been doing quite a bit of work on. Here we've got Achilles, dipped in the river Styx to protect him by his mother, held by the Achilles, and that was, of course, his little vulnerable point. It's a fairly easy diagnosis to make. This baby's made the diagnosis in a fairly straightforward fashion. And of course, that was his downfall. And this is a term, an Achilles heel, that's gone into common usage, isn't it? It's in normal parlance, indicating that the mighty are laid low by this apparently simple problem. But it's an astonishing piece of kit, our Achilles tendons. So tomorrow, there's going to be a lot of people running this course. I think I have a pointer. Most of the biggest chunk of the marathon in terms of boroughs is in Tower Hamlets, so it goes near enough past my house quite regularly. And I see apparently it's going to be 45, maybe 50,000 people tomorrow using their Achilles tendons to do astonishing things, running at incredible speed, getting around the best they can, celebrating in costume. Some of them in wheelchairs, maybe not using their Achilles so much. So this is not science. I'm worried about what Nick's going to say now. But this is literally back of an envelope calculation, just to share how brilliant I think the Achilles is. So if we assume a cadence of about 160 and a 4-hour marathon time, please don't take photographs of this. There'll be a fundamental flaw in my sums. So I reckon somewhere around 40,000 steps per runner, okay? I went with 40,000 runners, so 1.5 billion steps. And then there is a bit of science coming. This is a really nice systematic review by Rod Whiteley's group. And if we assume something around the sort of time that I've indicated, then we're looking at about 5 to 6 body weights per stride, per step. Okay, if we multiply everything together and just get a great big number, we're looking at a huge number of body weights, 7.5 to 9 billion body weights, just in the 40,000 doing the marathon. And if you up that by 10%, you can up that by 10%. And if you think about all the people around there. So it's an absolute triumph for the Achilles tomorrow. And hopefully all of you, your Achilles will triumph if you're doing this. And it's an astonishing piece of kit. It's an incredibly strong tendon. It stores energy and releases it. I was very much taught that it was the muscle that did all the generation of force, but of course what the tendons are doing is deforming massively, anything between 7 and 18%. Okay, that's not just Achilles, that's positional tendons too. Now, given that collagen and the collagen fibers, so the smaller bits, the fibrils, hardly deforms at all, a few percent. So what's happening is we're getting sliding in this interfascicular matrix between the fascicles. We can see the fascicles. That's what we can make out with the naked eye. And it's probably where tendinopathy starts. Certainly we've got some really interesting data, which I'm not going to share today just because of time, showing that all these cells in the interfascicular matrix and the properties of the matrix are what changes with age and with injury. And we're working on ways in which we can try and assess that. I'll show you one slide at the end if my timing is amazing. And then those are arranged in bundles which spiral down onto the heel. And all of that deforms and gives the energy back in that energy storage and release phase. Beautiful structure. I'll put this up at the end again. I'm taking most of this from these publications, so you don't need to write anything down. Think about the ideas, and I'll put this up again at the end. You can look things up if you're particularly interested. So it's a triumph for most people. And I wouldn't be here talking about Achilles tendinopathy if it wasn't a big problem. So here's a structurally compromised Achilles tendon, not necessarily symptomatic, but disorganized, thickened, neovascularization, all the things you don't want to see in an Achilles tendon. And what do we know? It's a clinical diagnosis. It's a fairly straightforward diagnosis, as I said, a localized pain on weight-bearing activity. You maybe want some imaging confirmation. There's a few masqueraders with some subtle tears and plantaris issues and so on that you might want to know about. In everyday life, 35% of cases are people who don't do much physical activity. There's an overall incidence and prevalence that we know from Dutch and Danish studies, but it's really high in runners, okay? 18% of running injuries. This is, depending on which population or which sampling route you take, you'll get different numbers, but it's high. And this is a really nice study from DeVos's group, a prospective study showing sort of 4 to 5% incidence over the sort of something approaching a marathon training type of schedule. We know progressive load is the treatment of choice at the moment, okay, and I'm going to share some stuff around that. And there's many intermediate interventions, and I think following on from Nick's work, one of the reasons for there being so many other approaches taken to difficult problems is our main approaches don't work well enough. So people are desperately looking for solutions. Some of these intermediate interventions probably work, but anything up to 60%, again, the figures vary, will have problems at 5 years. Our treatments are not good enough. They simply aren't good enough. Tendons are really poor healers, and they need a lot of help, and they need a lot of input. So one of the things we've done is a trial of two of the most promising intermediate interventions, high-volume injection therapy and shockwave therapy. And this is an NIHR-funded trial. We've recruited 185 people. We've finished the trial now. I'm just wrestling with the analysis, and we'll submit this soon. But it was in adults with at least 3 months of mid-portion Achilles pain with a primary endpoint at 12 months. So we were looking at long-term follow-up using the VISA-A, which has problems, but it does the job. And again, looking at this, these are the interventions. Here's the high-volume injection. Needle goes in deep to the Achilles tendon, and then a bolus of 50 mils of fluid is put in. Different people use different things. We used local anesthetic and saline. We didn't use steroid. We probably should. But because the original trials did, but we thought we'd start without. So we've got another trial in Australia comparing steroid versus no steroid. And you can see the stripping away of the fat pad deep to the tendon in this very tendinopathic tendon. And typically we see quite a reduction in pain and a change sometimes in range. And then the other should be running. And this is Zubair, my wonderful clinical research lead for the duration of the trial. Using shockwave, which again has some systematic review evidence in its favor. The real intervention, of course, was progressive loading. These are things added to progressive loading. Everyone got this, and it's a really good program using a standard pain monitoring approach, so they progress if they're in the green or the amber, and either stick or dial back a bit if they're in the red. And then there's a graded calf loading, Achilles tendon loading approach. And people start at the level at which they're comfortable and progress from there. So it wasn't a recipe. It was very much staged to fit with where somebody was and getting up to speed and impact. And I think that's really important. And they did some cardiovascular work. They did some weight-bearing muscle activation, and they did some heavy load training of the rest of the kinetic chain. So it was a very complete program. So here's kind of the results. It hasn't been peer-reviewed yet, so I'm just going to keep you away from this a little bit. And I won't tell you what the colours mean. Hopefully it hasn't snuck through. It hasn't. But what we can see is that there isn't one group that's doing anything spectacularly different to the others. Okay, we're seeing a progressive change. We're seeing a positive change over time. And what I've done for you is to summarise where the whole group started and where the whole group ended. Because ultimately, trials are designed to look at effects, comparative effects of one approach over another. What patients are interested in is outcomes. You know, if I have this treatment, where am I going to get to? Okay, and these are outcomes. And what you can see, this is on a Visa A, so 50 is pretty bad. You can just about run, maybe. 80 is pretty good. You can definitely run, but you'll be compromised. Getting up towards 90, much better. Okay, so we're not getting everybody to where they need to be. That's the big issue, and we've got a lot of variation. So what we need to do is to target, either have new treatments just work better, full stop, or to target treatment far better. And we've been saying this for years that we're lumping together people who are very different and expecting similar effects. I think now the science is changing radically with big data and with genomics and so on, that we can maybe target things much better. I'm going to share a little bit of that in a second. So we're going to go on to a second piece of work where we've done some more formal intervention development. Don't read this. It's long-winded. It's really, really interesting. And if you want to read it, then go for it. But it's geeky stuff that's not for a Saturday morning. So I've summarized it, but this is proper intervention development. So involving people in devising an intervention, testing it, developing the science, developing the theory, looking at the feasibility of the intervention are all things that we need to do. So, and where we want to get to ultimately is to precision. That's probably my next step, but here we're going to do some intervention development specifically for runners, because I think the standard approaches don't work well for runners, aren't set up well to work for runners. So this is my summary of this, and this works by Igor Sancho as part of his PhD, and also an HTA-funded set of systematic reviews which are either published or in press and coming very soon. And I'm going to talk about some bits of this as we go through. So, bang on time, I think. So qualitative work. Finally, we're talking to people about what they want and what they need. And it's really interesting talking to patients and to clinicians. I've done quite a lot of this for best practice guides for various conditions. But talking to people in a structured way, qualitative work, gives an insight which is quite different to the quantitative trial-based data. It's really incredibly rich. And people talk about different things. They don't say, I want this intervention or that intervention. They tell you how they want the process of care to be. And considering that sort of organizational, contextual, and sociological and psychosocial component of delivery of care is absolutely critical to outcome. Because ultimately, we're talking about progressive loading as an intervention. If people don't do it, if they don't buy in, then they're not taking the drug, right? They're not getting the intervention. So this was for all exercise studies, for all tendinopathies, qualitative work, and we ended up with 128 participants across 11 studies, which were boiled down by my brilliant collaborators at RGU, and we ended up with 2 synthesized findings. That's fantastic, isn't it? You know, you're looking at probably about 130 hours of conversation down in 2 little boxes. There you go. So synthesized finding 1. And there was really good agreement between patients and healthcare professionals, okay, for all of this, that people present in very different ways and have very different experiences and opinions. We know that from treating patients, that makes sense, but that's a really relevant part of delivering good care. Lots of barriers and facilitators to adhering to exercise, and if you're interested in this and have a look at the behavior change theory, models that are out there, this is really underpinning our understanding of adherence and of how we can take someone who presents to us at a time when they can make you can make a difference. They're in a behavior change moment. We were doing some work in that in Australia. And what we need is an individualized approach. Do not use a recipe. Okay, we need that to be focused on that individual and tailored to them. And equally, we need to focus on education, and I make this point really strongly. This is not provision of information. This is teaching people how to deal with the problem, teaching people, which involves checking learning. Okay, I'm delighted if my students get 70%, right? If they get a distinction after a year of study with all of the pedagogy and all of the tests and all of the revision and all of the peer learning, they get 70%, I'm delighted. We expect our patients to hear something once and to remember it, and then to do something differently. It isn't going to happen, is it? Okay, we need to have proper education based on a trust and trusting therapeutic alliance, so that we can get good motivation and confidence in the exercise intervention. So these are real descriptors of quality of care. What we don't have yet is this work done with runners. So if anyone's looking for a qualitative research project, that's a wide open space. It's probably coming. So what about some laboratory-based work? So Igor did some work in Australia and in the Basque Country. He did his PhD a bit. He lives in San Sebastian, which is a terrible place to live, apparently. It's terrible food, terrible weather, terrible views. He wrote most of his PhD in his ski lodge. And then he'd come to Mile End to go through it. And they'd set up a lab for him and a colleague, which is pretty tatty. It's a horrible lab. He spent most of his time either going to Australia to work with Peter or coming to London to work with me, so he had a tough time. PhDs are horrible, don't do them. Yeah. So this is some work we did looking at 11 different exercises, 11 different things that we might do with people with Achilles tendinopathy, and then model it. So this is someone hopping, the same data, hopping across the lab, thankfully landing on the force plate so that we can calculate the Achilles tendon loads. Again, in body weights, just like the first slide. And he did this very nicely with 24 people. And these are people who, just point out a couple of things, the visa A is 57, so not dissimilar to the entry point at my trial. Okay, so these are quite significantly affected, but still trying to run, so keeping runners running. This is my slide that is very much talking to that. Okay, they were a bit older, they were all male runners, and what's different about these compared to previous work, Karen Silbernagel's group's done some quite good stuff, is that they have Achilles tendinopathy. And here we've got two bits of the output which I think are most interesting. You've got two clear groups. Statistically, these are very distinct. If you do a dendrogram, they fall into two boxes, but you can see it with the naked eye. You've got this group, low variation, okay, and low loads. This is body weights, so this is around the 3 level, way below running. I would ignore the walking data a bit because walking is a bit different, but certainly these are akin to the heavy slow resistance or the progressive loading or the Alfredson type protocols, okay, and they're not preparing people to run, okay. Running is up here. Again, notice this is quite tight because running is a really learned, especially in this group, is a really learned motor pattern, whereas the others aren't necessarily. But what you've got is an overall mean, which is much higher and akin to running. There's not much difference between these, which surprised us a bit, it has to be said. But a lot of variation. So people are doing things in very different ways, and unpicking that data is a future challenge, if we can. But what you've got is two distinct groups. And if you're not doing this in your rehab program with runners, then you're not getting them ready to run, that's for sure. I love this. Igor doesn't, but he'll get there. So this is pain during the activity. Now, we didn't specify what they did in terms of pain with this particular experiment. And this is the same two groups, okay? And you can see there's no difference in pain, not really. There's a huge amount of variability in all of them, quite different to the last slide. And what this says to me is that you're getting much more load into the tendon with these activities per unit of pain, for the same amount of pain, as you are with these. And to my mind, this is a big safety indicator. It's okay to do this stuff. Get your patient right, monitor pain, it's okay to do this stuff. People are scared, I think, often to get people doing the higher loading, the stretch shortening cycle, the impact loading, because often that's what people come in saying that's what they can't do. So, on to some feasibility. And again, this is published work. So we kind of developed these things alongside each other. So this was actually published first. So this is a program. Again, it's out there. So starting with someone who's more severe, so some criteria for where they might be, and starting with really simple things, and building up some lower limb rehab, quite similar to what I've shown you already, and then adding in a specific jumping and ultimately a hopping and running program. So that's the rehab. It's all very straightforward stuff. And if they're tolerating that, they would move to level 3. This is Igor. And this is double leg jumps. He would do 180, he's not doing it here. And then these stiff knee, these are hard. You should try them. And then forward and back. Back is hard. And then up and step. And counting these and monitoring pain during these, so we're getting a good appreciation of, and they were doing this 3 times a week, good appreciation of what happened. Right, I'm going to give this a go. I wasn't going to do this, but I am. Everybody stand up. You should have just enough space. Move your coffee cup. I kicked mine over when I got up. Right, you're going to do 180. No, you're not. Karen Silbernagel would have you do about 280. Okay, so double leg jumps. Double leg jumps. Go on then, go on then. I like this. Now try and do it with a stiff knee. Don't move your knee. Feel what happens. It's hard, isn't it? Okay, well done, well done. You're awake. You look great, by the way. It's amazing how I can tell jokes and you don't smile, but you stand up and bounce up and down, and you definitely do. There we go. Moving on, so the hopping. Okay, guess what's coming next, by the way. So this is the single leg hops, similar sort of numbers. And then the stiff leg hops, which are really hard. Forward and back. Again, the reverse hopping is tough. Okay, he does do it beautifully. So this would be once a week with a phased running program. Okay, so there's the intervention. And as I said, the main outcome of this was not about efficacy. We don't know if this works for Achilles tendinopathy. It wasn't set up to do that. It's a feasibility study. Can we get people to do it? Is it safe? Are there indications of safety? What are the initial indications of efficacy as a secondary outcome? So this is proper intervention development. And look, this is pretty good. Okay, most trials do not of exercise for anything, and certainly for tendinopathy, don't report adherence, even when they say in the protocol that they're going to, because it's a nightmare to measure, and it's often really quite poor if you do. Okay, I won't share the data on that. It's coming soon, but this is pretty good. They're doing about 60-odd%, and what you've also got is fidelity, which is how well they did it, and interestingly, the jumps and hops are often not done particularly well, even though they engage with it pretty well. So there's a skill component here, and there's a lot of teaching on how to do these properly. And you had a little bit of that with the double leg and the stiff knee, and you can see how there are some difficulties. And they did okay with the running. Okay, they didn't always stick to the prescription. Funny that, runners don't always do as they're told, right? So it looks pretty good in terms of adherence and flexibility, fidelity, pardon me. In terms of retention and in terms of adverse events, we had 15 people go through the program, and we had 2 drop out. One got a knee injury. He felt much better, so he went and played football and hurt his MCL. And the other one got a calf tear, which probably was a result of the intervention, because he was doing all of this and building his running. Again, he did too much of the running and tore his calf. But that's absolutely an adverse event. And we've got to be thinking about adverse events, not just positive effects. In terms of just indications of efficacy and of mechanistic change, what we saw was a progressive change in leg stiffness over 12 weeks. So the function of the lower limb is improving. It's good to have a stiffer leg. So this is flight time, this is spring, this is what we want, and is often lost both within the tendon and within the limb as a result of injury. Hopping to fatigue improved somewhat. There was a good trend. And then stiffness during a hop to fatigue also improved. So we got some nice indications of change. So I think we've got an intervention that's probably ready to trial. I'd like to do a little bit more qualitative work. I said I would put those up. They're up. You can have these later. I don't think I've got time to do this, but we are looking at ways of trying to bridge this structure-function mismatch, and Gamal's just published his PhD. This will be coming very soon, where we can image and see different parts of the tendon moving differently. And we know that that's associated, as I said earlier, with injury and age. So I just need to do as I normally do. These are the funders of the work that you've seen today, and that's the team the academic team, and more importantly, too many clicks. This is Igor and fellow supervisors. These are my PhD students in the last couple of years, some of whom have just graduated, thankfully. There was too many of them, but they are amazing. Thank you very much. Three minutes questions.
Thank you very much, Dylan. We do actually have time for one or two questions on this one. So would anybody like to kick off the questions?
Be as gnarly as you like, because this is the bit that's exciting from my perspective.
We've got one at the back.
So can I just ask, can you pop the that's quite scary, the papers back up, please?
Yeah, that's one for the AV guys. Can you put the papers back up? Do you know what? If you email me, I can send you most of them. Is the other thing. I'm allowed to do that.
Thank you.
Yeah.
We will have recordings of the talks online as well this year.
Tell me that.
So you'll be able to go through and find things that way.
I'm glad I did the disclaimer for my sums at the start of the body weight. I was done on the train yesterday, which was very delayed.
We've got one more question at the front here.
Has the research resulted in a treatment protocol yet, or is that still in the process?
So that's the treatment protocol, yeah, and that's in physical therapy and sport. So you can see that. I give it to my patients now. I'm using it with patients in late stage rehab, and I've literally made an Excel spreadsheet which has my prescription specifically for them, and then a photograph of the 4 stages and the exercises that go with it, and I put lines through bits I don't want them to do and focus on other bits they want to do, and then record that all on their own phone so they've got it with them to take forward, which I think is probably my single biggest tip in terms of promoting adherence and fidelity, is getting someone to do the rehab prescription, and you film them and you correct them as you go so that they've got that right there and they can see what you've corrected or the advice you've given them and hear the reps, the sets, the rests, etc. Pain monitoring.
We've got time for one more in the middle here, and then Courtney at the front, and then we'll move on.
Fine. Do you think your treatment protocol has space for weightlifting?
Definitely, yeah. I flipped over that a little bit, but what we need from an Achilles tendon perspective is you need heavy, slow load to stiffen it. What you need from a whole limb perspective is that the hopping and jumping program, for example, to get that overall lower limb stiffness. The difficulty we've got is we can't put everything in. You know, you've got to get something that's feasible, and a lot of people are real proponents of having 2 or 3 things that are the key things that you do, and there's a lot to be said for that. Depends on the group. But if someone is doing a regular training program and you can interface with that, then there's more that can be added. But I think you definitely need some strength. One of the bits of data I didn't present was a case control study with 44 people with Achilles tendinopathy, 44 without, and comparing them on all sorts of measures. And interestingly, soleus strength and hamstring strength were significantly lower in the group with Achilles tendinopathy. And these are all people who are currently able to run but struggling with Achilles tendon pain. So there's definite deficits to be considering in these groups.
Dylan, can I ask, thank you very much for your talk. Can I ask a point of clarification? In one of your last slides, you mentioned stiffness. Now, lots of people, runners included, obsess about stiffness versus flexibility, but I suspect you're talking about something different.
Right, oh gosh. So I'm considering, I've been talking about writing this editorial for a long time about ST words, stiffness, stretch, and strength, which are so ubiquitously used to mean all sorts of different things. And now that I'm doing lots of work with dancers, it's opened another whole thing about stiffness. So stiffness, I'm specifically talking about flight time to contact time of the lower limb in this instance. Not the feeling of stiffness or the play within the tissue. It's a performance measure. If we were measuring Achilles tendon stiffness, that would require measurement of both the tendon elongation and the specific load that's applied, which you can do with sort of specialized kit. We've done it. It's a big old job. Yeah.
Okay.
Gosh.
I'm sure
so yeah, this was a performance measure of stiffness.
Yeah,
which we can
sounds
do.
like we could continue that conversation for a while, but we'll maybe do that one after.